My name is Ursula Gallagher. I'm the Director of Quality and Patient Safety for Brent, Harrow and Hillingdon CCGs, and my business address currently is The Heights, Lowlands Road, Harrow.
And in front of you you'll see some documents. Volume 2, could you please turn to page 61? Now, slightly unusually, this isn't your document, it's a document prepared by Dr. Kong, but your role, I think, is to speak to it.
611.
561.
561. Oh, right, okay.
Should be a letter dated 23rd of February from Dr. F.E. Kong. Is that the evidence you wish to stand with your evidence before this commission?
Yes, it is.
And there's a further document, and it's a volume 5, and it's at page 1855 to 1856, and this is a further letter from Dr. Kong dated the 30th of March this year. Again, same questions. It's almost at the back of it, yes?
Yeah, I'm almost at the back, thank you.
It's the same question. Is that the evidence that you wish to stand before this commission? But can I just check, first of all, about your roles? Am I correct? You have one role with Brent CCG and another with Shaping a Healthier Future?
No, I think that... So, let me explain. So, for Brent CCG, Harrow CCG and Hillingdon CCG, I am the Director of Quality and Patient Safety, and I'm the nurse member of their governing body. In those roles, I am a member of the clinical board for the Shaping a Healthier Future programme. So
the descriptor that I've heard, Director of Quality for SaHF, is that a misnomer?
Yeah, it's represented as a misnomer, yes. There isn't a Director of Quality employed by the SaHF programme. SaHF is a programme of all 8 CCGs working together, and therefore one of the things that we do when working together is people in substantive jobs within the CCG and trust teams contribute to the work of the Shaping a Healthier Future programme. So I'm not employed by Shaping a Healthier Future.
Can I just be clear, because this may just be me.
No,
to whom do you report then?
So I report to the accountable officer of Brent, Harrow and Hillingdon CCGs, and I report to the clinical chairs of the 3 CCGs. I'm not within the Shaping a Healthier Future reporting structure.
Right. Who's the accountable officer?
Mr. Rob Larkman.
Now, I just wanted to ask you this. I don't know whether you're able to help, and obviously, if it's a reason unconnected to these issues, please feel free not to answer, but can you help with why Dr. Kong isn't here to speak to her own evidence?
No, I can't. I think that because I've had a wide involvement in the programme, it was felt that I was the best person to represent the views of all of the CCGs in relation to the 3 CCGs that I work for in relation to Shaping a Healthier Future.
Right. It's just that it strikes one as slightly strange because, of course, we've had Dr. Spencer and we've had Dr. Palmer who's speaking very specifically to Ealing. And I wondered, do you think it would have been helpful for Dr. Kong to have been available?
I can't comment on that. I've been asked to be available and I'm very pleased to be here.
Can we start briefly then with the closures of A&E at Central Middlesex and Hammersmith Hospital? As I understand it, the position of Brent CCG is that the problems which then ensued with missed waiting time targets weren't related to the closures. Is that correct?
No. I mean, the missed waiting times, as we've argued, North West London Hospital was already missing the waiting times target for a number of reasons. The decision to close Central Middlesex A&E department was part of a strategy to address those issues, but the coincidental issues that Dr. Spencer already talked about the sudden national surge in demand that happened within the A&E department, was not directly related to the A&E closures.
Are you saying that the closure of 2 A&Es simultaneously didn't create any extra pressure at other hospitals?
There was the planned for changes. So there are two bits of the jigsaw puzzle. There is what we planned would happen, for which we had planned very carefully, and I no doubt you will ask me some more questions about that. And then there was the completely unpredictable issues that happened, particularly the very early arrival of the winter surge.
Can I ask you just this? Obviously they're both close together. Are you saying that the closure of either site singly wouldn't have created pressure elsewhere either? That's one of the reasons why we decided to close them together in the planning process. That actually, because a serial closure, so if we close them separately, there was a risk that the initial flow, given how close they were, Central Middlesex and Hammersmith, there was a significant overlap in the population flow between those two departments. Given that those were both departments under considerable pressure already, not so much in terms of numbers, but particularly in their ability to safely staff those units, there was a very explicit decision taken to plan to close them together so that we didn't actually end up with a number of weeks with increased pressure on one or the other that we knew it wouldn't be able to cope with. And those were the recommendations of the clinical directors in both of the trusts. So can we just follow that through? Can we have a look at page 563 of Dr. Thomas' submission? And it's the last paragraph. And what she says, and I think this is what you're saying, following discussions, it's agreed that the A&E departments should plan to close at the same time, as this would cause less confusion for publics and patients and prevent displacement of activity to the other site if one closed ahead of time. Is that's
essentially what I was saying.
If you shut one and people have to move to the other, that creates pressure on the other, doesn't it?
Yeah.
So if you shut two, doesn't that create pressure on what's left?
So it's about, we didn't shut until we were sure that the other sites could cope with the planned move of patients. What we didn't believe would happen, and what the clinical directors clearly told us would happen, was that there were plans that we could put in place to enable one to cope with the short-term displacement if we closed them serially.
Okay, do you think that the plans for the closure simultaneously worked?
So there are a number of elements to that in terms of the primary purpose of shaping a healthier future, which is about providing improved care and safer care for patients. Then the answer to that question is yes. It is entirely acceptable that, given what also happened with emergency care demand both in London and across the country, that it could seem as if we hadn't planned properly. We planned properly for what we expected to occur, and even for a degree of unexpected occurrence, we got something that was completely unpredictable.
It was completely unpredictable that closing two A&Es at the same time might create pressure on that which remains.
No.
Is that what you're saying?
No. I said what the impact of the planned closures, based on the evidence of numbers and what was going to move, we had planned for, and I believe that happened as planned. In addition to that, there was an unplanned, unpredictable increase in emergency activity, which, as Dr. Spencer said, we saw right across the country. And even though we had built in some 20% contingency to our plans, it wasn't sufficient to cope with that completely unexpected excess of A&E demand.
You attribute, am I right that you attribute the problems of missed targets to winter peak? Is that right?
Well, part of the issue was that it wasn't even, one of the reasons why we were closing in September was to try and make the changes before the winter. So it was an unplanned, it was a completely early surge.
So the problems that ensued at Northwick Park, with 4-hour targets being missed on a very regular basis, do you say that they were due to seasonal variations?
Yes.
So if that's right, why do you think it is that they're still missing their targets by some considerable way?
Well, and Northwick Park weren't achieving the target before, so part of all of this was about, so Northwick Park has a trajectory in place to improve. The impact of the winter was that it fell below being able to achieve that target, and it is now seeking to get back on track to deliver that target. And the changes to the A&E services and the concentration of services, and particularly the concentration of staff in the Northwick Park A&E department is all part of helping that to happen.
So can we just unpick that slightly? Northwick Park wasn't delivering the service it should have done before the closure of the 2 A&Es. The 2 A&Es closed and it continued not to deliver the service, and it's still not delivering the service. How is that good patient care?
It's good patient care because lots of the things that were driving, because clearly the waiting times are only one aspect of what we look at when we look at quality. So, for example, Ms Benson will be much better placed to answer the detail of some of these questions if you wish to put them to her later, but some of the big issues were about the number of consultants able to be employed in the A&E department, the number of temporary staff that were in place across both of those sites that we were able to consolidate together. So actually the quality of patient care has been improved, although the waiting time targets have continued not to be able to be met.
Is that a concern for you?
Yes.
What's being done to address it?
So we've had a further joint investigation of what's going on. The Trust have had a great deal of additional support, and there is a remedial action plan in place with the Trust, which is monitored on a weekly basis to access some of those improvements. Some of the other factors included London Ambulance Service, and we've worked with London Ambulance Service in terms of how 999 patients particularly flow around the system with the use of something called intelligent monitoring.
Have we had that report made available?
The Remedial Action Plan report? If you haven't, I'm very happy for you to have it.
I wanted to move on now and ask a little bit about population, because of course it's right, isn't it, that SaHF is quite an ambitious programme, and it's based on future predictions of a number of things, including population. If the population data is wrong, that's going to have a knock-on effect, isn't it, on the calculation of service need?
Potentially, yes.
Yeah. So, if there's a substantial development like that at Old Oak Common, which, with the best will in the world, nobody knew was going to be signed off as something to happen in 2012, that's going to have a substantial effect on the population figures, isn't it?
Potentially, yes.
So, the figures I've seen for Old Oak Common vary, but the most consistent ones seem to say 24,000 new homes, and the conservative ones, 24,000 new homes and 55,000 new jobs. Is that going to have a major impact on the population of this area?
If it happens as predicted, then clearly yes.
Is that going to have a major effect, a major impact on the SaHF plans?
It will need to.
And is it safe to assume, because of course we know that part of the rationale behind SaHF is that there's an ageing population and greater comorbidities and so on. Is it safe to assume that any population that moves in, whether or not it echoes that profile, just by force of numbers, it's still going to have an effect, isn't it? So even if it's a young, fit, healthy, rich working population, they're still going to need services.
Absolutely.
And those haven't been factored in yet, have they?
So one of the challenges of the Shaping a Healthier Future programme is, A, it is, as you have said, extremely ambitious, but it is also quite a long-term programme, and therefore it needs to be constantly refreshed as new information, both about clinical evidence and population, comes on stream, which could include population growth linked to developments or not.
So would it make good sense to pause and review at the moment, based on, particularly looking at the Brent situation, well, although, of course, the Old Oak Common crosses borders, but would it make sense to pause and think, how is this going to affect? Do we need to relook at our figures? Do we need to relook at the reconfiguration? So
pause, no, and that's why things like, so that's why the Shaping a Healthier Future data is continually refreshed. It's why the draft INBC business case process will include the latest, most up-to-date information that we have. Of course, we are under obligation to be dealing at any point in time when we make a decision, not with 2012 data, but with 2015 data.
Do you know, you referred to the INBC, do you know whether it includes this new data and information or not?
I certainly know that refreshed data was supplied to the INBC, both on activity and population.
By who?
By the people working within the programme.
Can you be a bit more specific?
No.
Do you know, and have you seen the IMBC, and are you able to say whether you know if it's taken account of this new data or not?
So I've seen the very early draft that Dr. Spencer saw,
yes.
And certainly for the 3 CCGs that I work for, I recognise the data as the planning data that we were currently using, which, as Dr. Palmer said, is not the same as the ONS survey data. So in terms of registered populations and our own plan for population growth, which in Brent does include understanding, as best we can at the moment, some of the major plan developments.
So, is the answer that in fact that you, and I'm not being critical at all, but that you haven't seen the IMBC in its updated form, so you don't know how those things have been factored into it? Right. Now, just turning to a slightly different subject, Dr. Kong sets out, and this is at 567, she describes Brent CCG as being the coordinating commissioner for London North West Healthcare Trust, and it says that as such it undertakes all contract, clinical and governance meetings. Can you explain a little bit more about that role, please?
So, given that many patients in North West London and outside, but in North West London receive services from a number of trusts across the area. We have a system which we call lead or host commissioning, whereby one CCG leads on working with the other 8, the relationships with all of the trusts. For Brent CCG, that relationship was with North West London Hospitals Trust and is now with the London North West Healthcare Trust. So the contracting team is based within Brent CCG, and I, as the lead director for quality and patient safety, am involved in all of the discussions with respect to clinical and governance meetings, for example, the Clinical Quality Committee.
And does that indicate that Brent CCG holds within it a high level of expertise and experience in terms of contracting and commissioning issues?
Yes, both within the CCG itself and with the shared service arrangements that we have in place across North West London.
And what are the shared service arrangements? Sorry, just very briefly.
Okay, so we have a number of specialist people. So some people work specifically for individual CCGs, and some people share their expertise across a number of CCGs. Right. So I share my expertise, such as it is, across 3.
So when we turn to looking at the out-of-hospital strategy, the CCG, presumably, would apply its expertise to the commissioning and procurement services?
Yes, and it would seek additional expertise if it felt it didn't have everything it needed in-house.
So can I ask you, please, about the musculoskeletal and gynecological, I can't even say it, gynecological service procurement? Please.
Yes.
Page 571, in February, what Dr. Kong said was this. These services were being developed, and the evaluation of pilot schemes have shown good evidence of improved clinical outcomes. But then if we move on to volume 5, and that's the second document, this is the letter dated the 30th of March, that process seems to have ground to a halt. Can you help the Commission with what's gone wrong?
Could you, when you're referring to paragraphs on pages, to indicate where they are?
I beg your pardon. It's slightly difficult because, of course, none of the paragraphs are numbered. Yeah. In fact, in terms of the paragraph of 571, the references, I think there's 3 bullet points. And the 4th bullet point down says we're developing consultant-led community services to include gynecology and musculoskeletal services. And there's an indication there about the progress. And then later on, in volume 5 at 1855, in substance it's the totality of the letter, because what the letter says is this. The CCG governing body has decided to discontinue the current procurement exercises for gynecology and MSK. We understand that this may come as a surprise to many stakeholders, etc., etc. And then it talks about lessons learned, and it goes on to say we'll be arranging a meeting shortly for stakeholders involved in these procurement exercises, and we'll update further. And what I wanted to ask you was, in global terms, can you help us with what's happened?
Yes, I can. I'll do my very best. Brent CCG, again, pre-dating Shaping a Healthier Future, although obviously built into the Shaping a Healthier Future plan, developed a series of what it called waves of procurement around planned care. So those are mostly surgical, but not all surgical, separate from the emergency care pathway. We are in wave 2, which, as says here, included musculoskeletal and gynecology, and I think it's worth separating out in this conversation the two bits of the jigsaw puzzle. The first one is to say that first and foremost is about establishing a clinical case for change and redesigning a clinical pathway and model. And the second is then deciding what's the right vehicle for delivering that change. It all comes under the banner of procurement, but there are, as you know, a number of rules that help CCGs to decide which of the procurement routes they need to go out. What we have decided at the moment is that the original belief that the best way to do this was to go for a big procurement, put it in the European Journal and do a big procurement. From the things that we have learnt from cardiology and ophthalmology.
When you say the European Journal.
Sorry. So if you go for a big open procurement, there is a very set out legal process. You have to advertise it in the European Journal, and anybody from anywhere in the country or even anywhere in Europe can bid to provide those services. And as you know, the Health and Social Care Act lays down rules about how those decisions need to be made. So what has happened is learning the lessons from cardiology and ophthalmology, and we've said on a number of times today that we seek to be evidence-based and learn lessons through the programme, has caused us to say that although the work that we've done with patients and clinicians and others has made huge progress on the pathway and the clinical model of care, we are no longer convinced that a big procurement exercise is the best way of delivering that improved pathway and outcomes and experience for the patients of Brent, and that we will be looking at other ways of doing that that deliver the pathway we want to deliver, but not necessarily in obtaining it in the way that we had thought.
What's changed your mind?
The experience of cardiology and ophthalmology.
We'll come back to that in a minute, but can I just ask you, perhaps see if this chimes. West Sussex had a similar exercise. When Dr. Kong refers in her letter to lessons learned, she talks about outcomes and reviews of similar procurements relating to MS care. Is she referring to those exercises in other areas in the country?
So that was part of the information that we looked at. So our own experience from our Wave 1 and emerging national evidence across the country about how successful these things were being.
So is it the case that perhaps these things appeared to have been less successful than you originally envisaged they would be? And again, it's about unpicking. They all have different criteria of success, but certainly that they were more difficult, and therefore the benefit ratio, and particularly the time taken to get the benefit for patients, seemed to be longer and more difficult, and hence we're saying, is that the right thing to do? So, just thinking about that a little bit more, my understanding that there was an integrated impact assessment conducted by a consultancy firm called Mott MacDonald to look into the impact of changes, and that was due on the 6th of February. Do you know if that report is yet available?
I think so, and I'll happily find out for you.
I'd be grateful. And if it is available, is it something you can make public?
If we can, then I will make it public.
Now, you talking, or Dr. Kong talks, about stakeholders being updated. When will stakeholders be updated?
So it's my understanding that there's a piece of work. So there are a number of ways in which stakeholders are currently being updated. One of the disadvantages of being in a procurement process is that there are some very complicated issues about commercial in confidence that can make it difficult for us to be as open as we would always like to be at different stages of the process. So we have committed that within the next 2 to 3 weeks we will be in a position to share with stakeholders where we're going from here.
Do you know, can you help with what the aborted procurement process cost?
No, I can't.
Can you give us any kind of ballpark figure?
No, I can't.
Will you have to start from scratch?
No. Well, the honest answer is I don't know, but I don't believe so, because particularly the work on the clinical pathway and the clinical model has been done, and we don't have any reason to believe that there's no problem with the pathway, so we will just have to think about how we will go about implementing those pathways.
And are you able to help with, having said that you don't think a sort of full-blown procurement exercise is the way now, well, what is the way forward?
I think we would like to be talking with our local providers about whether there is a different way that we and they could collaborate together to deliver the pathway rather than a big procurement.
So is that another way of saying, can you keep the service where it is and just beef it up a bit?
No.
Is that another way of saying that you want to work with the existing providers rather than buying in from elsewhere?
We'd like to explore if the existing providers can deliver the model of care.
Can I be clear, are the existing providers the London North West Healthcare Trust?
No, again for Brent there are a number of existing providers which would include Imperial and the Royal Free as well as London North West.
But it is one of them?
It is one of them, but it's not the only one.
Okay, so you'll be talking to all three?
Mm-hmm.
And how public will that consultation and that process be made? That's subject, of course, to commercial.
Yes. And clearly, ultimately, the decision will be taken at our public board meeting.
Will the costs of the aborted procurement exercise be made available as a public document?
I honestly don't know, but...
do you think they should be?
Probably.
Now, let's just say for a minute these two services are up and running, the gynecological services and the musculoskeletal services. How do you say they might reduce the need for hospital admissions?
Well,
that's what they're designed to do, isn't it? It's designed to reduce acute need. How will that happen?
So, one of the things that we know about a range of long-term conditions is that if we can help patients to come forward for services earlier, so we can reduce the number of perhaps women who arrive in acute abdominal pain having a gynecological emergency. If there's an easier route, better support to GPs to help them spot and identify and diagnose issues earlier in women, and clear pathways by which they can come to community-based or other appropriate services pre to a crisis. The same with musculoskeletal. Clearly, there is, again, it divides into a number of bits. So there's the sort of acute musculoskeletal of perhaps somebody who has an acute back injury following digging the garden, or there are then people who live with a number of rheumatological and arthritic conditions, for again whom getting the highest possible quality of care with appropriate management both of the disease and of things like the pain and therapy support to support mobility and quality of life. So it's about how best do we do all of those things to prevent people, older people with poorly managed osteoarthritis are more likely perhaps to fall because they're in pain and not able to walk well, and therefore might end up with a fractured neck or femur.
Do you, I don't know if you do, but do you yet have a sort of percentage figure for the percentage of admissions, hospital admissions you think this is going to reduce?
That figure does exist. I don't know it off the top of my head, but again, I'd be very happy to get it for the committee.
And the same for gynecological service. Can I ask you to assist by providing an update about some of the other out-of-hospital services? Now, first of all, at page 637, there's a reference to a referral advisory service. So I think I may get the page reference wrong, but please understand what I'm talking about. A referral advisory service. Are you aware of that?
Yes.
Can you tell us how that's worked, please?
Okay, so one of the things that Brent CCG, along with everybody involved in the Shaping a Healthier Future programme in terms of our out-of-hospital strategy, is about improving general practice. And one of the ways in which we improve general practice is to provide support, advice and expertise to GPs in the delivery of their work. One of the issues, therefore, is about both the quality of the referral information, and perhaps the workup that's been done of a patient prior to that referral. The referral facilitation or advisory service is local GPs helping other GPs to be able to access some of their advice. The second thing is, in particularly through change programmes such as Shaping a Healthy Future, it's really hard, when I'm in surgery, it can be really hard to keep quite up to date with exactly what's changed, exactly what some of these referral pathways are, and particularly in terms of knowing how to refer patients to new services. So again, these sorts of referral services help to be able to help direct patients with and check GPs and patients to be able to be directed to the most appropriate service if the GP has been perhaps unaware that that service is available.
There's a suggestion from other ones that that service has been discontinued. Is that wrong?
I think that the principle of the service is recognised and valued. I think the precise way of delivering it at the moment is under review.
So does that mean that the service that was originally started has been, in its existing form, stopped?
I don't know is the answer. Whether it's actually been stopped, I can find that out with the committee.
Can you help us with how it came to light, or how you came to decide that that wasn't the appropriate or best way of running it?
No, I think what there was that my understanding is that there has been a pilot, and the discussion is about the evaluation of that pilot, about whether it continues or not. We need to learn the lessons from the pilot.
Do we know who's evaluating it and when?
No, but I can find out for you.
And do we know what the pilot cost?
No, but I can probably find that out.
I wanted to ask you, please, can you look at page 568? I just want to ask about a couple of specific points. There's a reference, and it's the second bullet point from the bottom, to Brent stars. Mm-hmm. There's a reference to an expansion of a social worker. Does that mean what it says, just one additional social worker? Extended our Brent to include a social worker to enable better links with the local authority.
I honestly,
I understand you're in difficulty. It's not your letter.
No, and it's although I did read it clearly. This has drilled into a level of detail that I wasn't expecting to be asked about. And we did say that if people wanted particular detail, there was an opportunity to advise us before we came. Certainly, I know that the whole conversation around STARS, which is linked to our Better Care Fund process with the local authority, is investing, whether it's a social worker in this bit of the team, but there are many more social workers in STARS.
Do you know whether the expansion of a social worker or a plethora of social workers, are you able to help with that or not?
No, I'm not. I couldn't be confident that I could give you the detail today. If you wish to ask me for the detail, I'll find it out for you.
And then just moving on, there's a reference as well, I think it's on 569, it's near the top, it's about sickle cell, second point. Improved care through an education and support programme in March 2015. It refers to a pilot. Can you help us with whether it's started, what the size of the pilot is, and when and how it could be evaluated?
I think it has started, but again, I will supply you with that information.
Brent Integrated Diabetes Service, same page, first bullet point, described as being too soon to provide a robust analysis as to whether it's delivering. Any idea when we'll know whether it's delivering as hoped?
No, but I can find out for you.
Cardiology, page 571. Now we know that the cardiology programme had some difficulties. Are you able to tell us whether or not it has hit its launch date, 2nd of March? Has it yet been launched?
Yes, it has been launched.
And where has it been launched?
The service is being provided from 2 sites in the borough, one of which is at Willesden.
And the other?
I can't remember, but
Can you tell us what the time frame will be for the analysis of whether this service is delivering?
This is a contracted service, so the evaluation is built into the length of the contract.
And can you tell us what that is?
I think it's 5 years, but again,
so
I can confirm that to you.
5 years, is that right?
No, there'll be ongoing evaluation through the programme.
And do we know when the first sort of information from the first evaluative work will come out?
At the end of the first year. I mean, I think it would be risky to evaluate these things too early.
Can I ask you please to look at volume 3, page 9.
I'm just looking at time.
We are running over.
We're going well over this, but it's time.
I've got
How much longer do you think it'll be?
2 minutes. I just want to ask a particular issue about this. If we look at that page, this is a...
Sorry, I've missed the page.
Sorry, volume 3, page 947. This is a London North West Healthcare Trust complaint against Brent CCG for the way the cardiology procurement was conducted. Were you aware of that complaint?
Yes, but I wasn't involved in any of the detail and may not be able to answer any questions.
About that. What I want to know is, has it impacted on the working relationship between the CCG and the Trust?
I don't believe so.
You're confident that that's the case?
I think, yes, I am.
Finally, my last question is that there's a reference in Dr. Kong's documentation, I don't think you're familiar with it, from about Brent CCG commissioning a report from Dr. Angela Coulter,
yes.
Non-medical Dr. Angela
Coulter. Yes.
Can you tell us how that came about, what it was for, and what the results of it were?
So, as with all CCGs, Brent CCG is committed to involving patients and the public in all the work that we do, as well as having a number of statutory duties that we need to deliver by law. We're getting lots of feedback from lots of stakeholders that our current arrangements were not working well, and that we were not doing patient and public engagement well enough. And we decided that the best thing to do was to commission an independent external review. Dr. Angela Coulter, as many of you will know, established the Picker Institute and is a recognised international leader in this field. Dr. Coulter produced her review, which was accepted in its totality by the governing body, and those recommendations have included a number of changes to how the CCG should be doing its patient and public involvement in the future.
Incredibly briefly, if you can. What did it say? What changes did you need to make?
It said that we should separate out the operational delivery and strategy from patient and public involvement from its governance. So the board subcommittee we had effectively was assuring itself that what it itself was responsible for doing. So in governance terms there was felt to be a problem, and that those two should be separated out. That we should strengthen our relationships with a number of partners, in particular the Brent Council, around the use of insight and intelligence and shared understanding of our resident population, and that we should strengthen our outreach work to work particularly with some of our hard-to-work communities. It recommended the removal of the strategy document from the Constitution, which was a strategy document should be able to be more iterative than you're able to do with it's in the Constitution, and that the local patient participation groups should also be removed from their role, their constitutional role, as a separate conversation about how they might continue to work locally.
Thank you. I apologise for taking rather longer than I intended. If you'd like to wait there, the next question.
I don't apologise, it was very useful. Thank you. Yes.
You'll end up thinking that's your name, won't you?
Well put. I appreciate your dignity because you're talking to somebody else's document. And also, once again, most of my concerns have been put by Ms. Reston. Just on page 563, there's a comment by Dr. that local commissions strongly supported The programme therefore proceeded with implementing these changes as local conditions strongly supported the ShaHF programme and the Secretary of State decision. As you can tell, I want to know what approval people have had from working with doctors and other clinicians. What evidence does Dr. Kong have, you think, that this was no more than the clinicians on the CCG and associated bodies involved? And what does she mean by local commissioners?
Local commissioners or local clinicians?
Well, I mean, what I want to know, that gives the impression, everybody reading that, gives the impression that all the GPs in Brent we're all for this, let's crack on. And all the nurses are all for the changes. But who are the local commissioners?
So, they're all of those people. In terms of the particular duties of the Clinical Commissioner Group, the Clinical Commissioner Group is a membership organisation, and all the practices within Brent are members of Brent Clinical Commissioning Group, and therefore there have been a large number of processes for consulting and involving those clinicians, and on a number of occasions there have been votes and decisions taken within that membership body. So in terms of the GP community, there has been lots of work. And don't forget that our GPs and myself, when I'm in practice, we have the first-hand experience of what services are working well, what services aren't working well, what are the challenges that we and our patients are experiencing.
Forgive me asking, but I've been like at front line as one of those GPs, and I have my suspicions about how decisions are taken and whether there's a true understanding or approval. If only the fact that half an hour before a meeting I might get megabytes of information to read, but that's not your concern. And one of the, again, I'll condense it down, just one other concern which has been you touched on just a moment ago. It's difficult for you, but there's a submission this afternoon. We've had witnesses that come this afternoon, KP&EGL, and in one of those submissions, actually on page 883, it refers to abolishing the Eden Committee and even the patient participation groups. That's the Quality, Diversity and Engagement Network. Now, having seen the quality of work done by these groups, aren't you not worried about the proposal to abolish them or even reduce their contribution?
So let's do... So, as I said, the advice of the independent review was that the Eden Committee should be changed, and that particularly its governance functions should be placed elsewhere within the governance structures of the CCG. The CCG's commitment, and that there will be a new committee established which will focus on the operational delivery of the patient and public involvement strategy. The local patient participation groups I can't abolish. They are independently established participation groups that sat originally within the Constitution. It was an anomalous that one group, that we need to be working with all our patient groups, with all our residents' association. The advice was that removing it from the Constitution is not the same as abolishing it. We know, can I just add one other thing? I think we know that in Brent that we have been extremely fortunate to have an extremely dedicated and knowledgeable group of patients and members of the public that have chosen to work with us, and that was acknowledged by both us and the Coulter report. The issue is the degree of ambition to do more and to do it better.
So we can have your assurance that you are not going to, in fact it's impossible to close the locality PPGs.
They are not our body to close. They have been removed from the Constitution, so they no longer feature as part of the constitutional structure, but they are independent groups.
God forbid the thought that you were trying to suppress the local customers.
If I was, then it's been a dismal failure, don't you think?
Okay. Thank you very much.
As I sit in front of them at the moment.
Just one thing I want to focus on. There's a reference on, again in Dr. Kong's statement, North West London, this is page 567 of the letter. North West London had the best performance across London. This is for A&E performance. In the quarter 3 of 24-15. This relates to the whole burden of A&E, obviously, in which, obviously, in the North West London, exceptionally high proportion is urgent care centre caseload. Is that right?
Yes.
I mean, you referred yourself to the fact of made the statement of a national surge in A&E towards the end of last year. I mean, that's not reflected in the figures. The figures of A&E total attendance at Type 1 actually continues to pretty much an average of 275,000 pounds since 2010, looking back on the figures. What's changed is the delays at Type 1 cases. Now, you're a director of quality, and I would have thought your main focus would be on the people who are most seriously ill and those needing most serious attention, which is the Type 1 cases.
Yes.
And, I mean, again, the figures show North West London from being one of the best in London, almost consistently right through to 2011. Suddenly, in the second half of 2014-15, became the worst in London by a long way, and the worst in England by quite a long way. I mean, for delays in Type 1 A&E. Now, how do you square that with saying that you're happy with the quality and the safety of the services being provided?
So the first thing to say is I referred earlier to the Remedial Action Plan. The Remedial Action Plan and the work led by myself and members of my team focuses entirely on improvement in Type 1 performance. Absolutely. From a clinical perspective, it is the Type 1 performance that is most important. What we have done, of course, is look at a range of things that matter to patients. So you're absolutely right. Delay in accessing a bed is a problem, and we are working with the Trust on that. But in terms of the other things that were consequential of the closure of the A&E department, a move from 4 A&E consultants to 14 A&E consultants, a significant increase in the number of permanent staff and nurses available, and the ability to monitor those patients more closely and to make sure that they are starting treatment, even if they're waiting for a bed longer, they're starting their definitive treatment early if they need IV antibiotics, and that they are receiving a range of care with respect to privacy and dignity, hygiene and nutrition. I'm confident, and I know, and either myself or a member of my team visit the A&E department on a weekly basis and talk to patients. I do know that the quality of care in the round, even acknowledging the issues about those patients admitting, waiting for beds longer than we would like, is improved since we closed the A&E department at Central Middlesex.
Sure, just follow on from that, but I mean, the other spin-off from that was, and there were pictures in a lot of the press about the ambulances queuing outside with patients who weren't yet receiving this consultant-led care. I mean, this also is a concern, and it relates to bed numbers, doesn't it? It
Yes.
relates to the capacity to actually admit patients. So have you been following that one through as well?
Yes, so and there are two issues about following that through. So in terms of the total bed numbers, the CCGs have commissioned a large number of additional step-down nursing homes, spot purchase rehabilitation beds, so that the actual numbers of beds in the system as a whole in Brent and Harrow are greater than they were this time last year. We have an extremely good relationship with the local council in terms of delayed transfers of care, and there are daily meetings to discuss that, to unblock any of the ways in which we can act together to move patients through the system, preferably home, but if not to home, to an alternative step-down facility, so that a patient waiting in A&E can access that acute bed.
And were those part of the original plan?
Yes.
Thank you.
I just want to ask you some very, very quick questions based on something you've covered. Can I ask you to look at page 637, please? Which are submissions that we're going to be hearing later this afternoon from the Brent Patients Participation Group.
Yep.
You looked at the bottom paragraph with Katie. I just want to make sure you look at the assertions that are put in that paragraph. You see paragraph 7.7?
Yep.
It says Brent CCG have introduced a GP peer-to-peer hospital referral advisory service. I think you agree with that, and you've explained that to Katie what that actually involves, correct? Goes on to say they repeatedly emphasise their wish to eliminate unnecessary hospital referrals according to the SaHF policy. Do you accept that that is repeatedly emphasised in the peer-to-peer hospital referral advisory?
Yes, I mean the SaHF is about, local where possible, centralise where necessary, integrate all the time. So supporting practices and local services that we put in place by not sending people to hospital services if they don't need to go there. Yes, the language is it's not my letter. I'm hesitating because I might not have written it in quite that way, but I think the principle is in line with the Shaping a Healthier Future principles, but also what we know is best practice anyway.
And the next sentence it says they, by which is Brent CCG, have promoted the US commercial Referrals Facilitation Service, RFS, to monitor referrals by individual GPs. This steer for GPs appears to contribute to patient referrals to A&E departments on a self-help basis. Did you accept that statement?
No, as I said earlier, I haven't read the evaluation report, so I can't. That's not an opinion that I recognise.
Then finally, the authors say they have heard from various members of the CCG staff that the RFS in its original form is to be abandoned. I think you indicated to Katie that's right.
Well, I indicated to Katie that I knew that a review was underway. Whether a decision has been taken to abandon it or not, I'm not certain. But I did say that I would supply the Commission with a definitive answer to that question.
I just want to make sure I understood. Thank you very much. Thank you very much for attending.